start with the overdentures. So I hope that all students, all dental students, and especially those who are interested in prosthodontics know about the statement. This is given by D1, that the perpetual preservation of what remains of human masticatory apparatus is more important than meticulous replacement of what is lost. This is, I think, the type of Bible statement you can say of the prosthodontics, right? So we are here always try to preserve what is there and not try to just replace what is missing, right? So think about this case. Now just imagine this case. If your patient comes to you with this kind of situation, would you like to extract the teeth and give the complete denture, or do something with this teeth, utilize this teeth and give a different kind of processes? So that is the basis of overdenture. Right. So what is the most common and significant sequelae of all extraction? When we call it complete extraction or total extraction, what happens is we are losing the discrete teeth, and that's why we lose the proprioception, the nerve sensation. Right. We'll go ahead in detail of proprioception later on. Then there will be a progressive loss of alveolar bone, what we usually call residual ridge resorption, which also you are aware of it. And then what happens is we transfer all the occlusal forces from the teeth to the oral mucosa. So what happens is this sequelae will make the complete denture progressively less retentive and thereby less effective. You know that bone loss under the denture is a continuous process. So what happens? Average of 4 millimeter bone loss happens vertically during the first year of extraction, whether with or without denture, right? And bone loss continues over 25 years, right? But when you are talking about the overdentures, this bone loss reduces to 0.6 millimeter vertically. That is the advantage of giving the overdenture, right? So what we know is the root of the teeth provides periodontal support, of course, but with the periodontal support, this has got all these things like the directional sensitivity, tactile sensitivity of load, dimensional discrimination. There is no surgical, because when we are talking about tooth here, we are talking about tooth supported overdenture. So if we are talking about the overdenture, it can involve the implant supported overdenture also, but implant support overdentures will require some surgical intervention, where tooth supported overdenture will not require surgical intervention. Then the canine response, again the proprioception, salivary secretion is controlled, and patients will have the psychological benefit of having teeth. So there are few definitions of the overdenture. Usually what we call it, overdenture is a process that covers and is partially supported by natural teeth, tooth roots or dental implants. Right? Or you can say the complete and removable partial denture that covers and rests on one or the more remaining natural teeth. So these are few definitions. You can write any of this. These are the different synonyms for the overdenture. Usually, I think your exams commonly asked terminology is overdenture only, but still you should know all the synonyms. What are the goals of the overdentures? So what we want is to maintain the teeth as a part of residual. This is because you saw the definition, it is only the partial, it is partially supported by natural teeth. Right? It is not completely supported by teeth. So you have to take the support from the residual ridge also. So you need to have the teeth as a part of residual ridge. You want to maintain the proprioception. That is some nerve sensation you want to preserve. Right? You want to reduce the rate of resorption of the ridges. Right? And achieving the increased manipulative skills for the patient. So what are the indications? Now see, some patients come to you, that time you realize that all the natural dentition what patient is having, they are in the compromised state, right? Either periodontally weak or caries conditions or RC treated and not restored. There are so many conditions where you feel that now this natural dentition cannot be preserved. So that is the first indication. Then there are the cases where retention of the denture will be difficult, like xerostomia, styleria, severely resolved alveolar ridges, congenital and acquired intraoral defects like maxillotomy, hemimandibulectomy, cleft palate, right? Few patients might have the poor prognosis of complete dentures, specifically like palatal, very high palatal wall and the ridge slope. poorly defined sublingual fold space, class 3 tongue position, knife edge ridges, right? Sometimes you realize, like this case, sometimes you realize that the prognosis of the FPD or RPD will be very poor, and you can preserve few of the teeth, then you can go ahead with the overdentures. Patients with badly worn out teeth, when complete denture will be opposed by retained mandibular anteriors, like this typical case, you will come to know about these cases later on also in single complete denture. So whenever you have this situation, the patient, there are all chances that patient will develop combination syndrome, and to avoid that, you can preserve this maxillary canines and go ahead with the maxillary overdenture. Patient with high gag reflex and few medically compromised patients. These are the indications for the overdentures. Then there are few contraindications also. First is uncooperative patients and poorly motivated patients. Some patients do have problem to manage this removable partial denture. Some patients cannot manage the removal. Then some mentally and physically handicapped patients, again, the difficulty will be the oral hygiene maintenance and manage the removable denture. And few patients, of course, cannot economically afford it because this will involve endodontic treatment, periodontal treatment, and the type of copings, means the casting and crowns and all. So some patients cannot economically afford it. What are the advantages? So first is preservation of bone, alveolar bone. As I said, you are keeping few teeth or tooth roots, so they will avoid the residual ridge resorption. So we are preserving alveolar bone. Second is proprioception. You have the periodontal fibers into that. You have some neural receptors which will give the sensation of the touch and pressure. When you do not have this connection is lost, and that's why the proprioception also is lost, right? Improved denture retention stability support, because you are giving the overdenture with different kind of attachments, sometimes without attachments also, but it can always improve the retention stability support. It can provide a vertical definitive stop, psychological acceptance, because patient feels that there are few teeth in their mouth. So they always have the psychological benefit of having teeth in their mouth. And preservation of masticatory efficiency, because again the teeth are there, proprioception is there, patient will have the sensitivity of the touch and pressure, right? And there will be less post-insertion problem. Then convertibility. Later on, if you are using some tooth roots now as a overdenture, later on you might require to remove those teeth. You can convert this overdenture easily into the complete denture. So that convertibility is one another advantage. Harmony of the arch form, because teeth are maintained, so the arch form will be maintained. The ridge resorption, like we have seen, the maxilla resorbs upward and inward, and mandibular ridge resorbs in the fashion of forward and outward. So that doesn't happen here, right? You can give the ideal occlusion. Open palate is possible because basically you are retaining this with some kind of attachment. So you can give the palateless denture. Less trauma to the supporting tooth. Aesthetics, because it has got the same to arch form, you are maintaining the arch and all, so aesthetic can be given better, and ease in construction. But any treatment cannot go without disadvantages. Every treatment has got advantages and they have disadvantages also. So overdenture treatment is very expensive because, as I said, it involves all the endodontic treatment, everything. It is bulkier than FPD or RPD, obviously, because you have the teeth roots, on that some coping, on that the attachment, over that the denture base, over that the teeth. So it becomes bulkier sometimes. Oral hygiene maintenance becomes difficult sometimes. The caries susceptibility, if the patient is having a high caries susceptibility, it is really difficult for the patient to maintain the teeth in position. Bony undercuts, if patient has the soft tissue undercuts or bony undercuts, it will be difficult and it will lead to the over contouring or sometimes under contouring of the denture. Encroachment on interocclusal distance. Interocclusal distance is one very important factor when you decide about the overdenture. type of overdenture. Whether you can give the overdenture, you cannot give the overdenture. If you decide to give the overdenture, depends on the intra arch distance. You will have to decide what kind of overdenture attachments you can use, right? And aesthetics, because it's like I said, it's bulkier, so sometimes aesthetic is difficult to achieve, right? And the fracture of the denture, because it has got so much of retention and support that patient's chewing efficiency is more and it leads to frequent fractures. Let's come to the types of overdentures. So we know that there are three types, usually the immediate overdenture, transitional overdenture, and definitive overdenture. So let's see what kind of immediate denture, right? Immediate denture, when we learn about the immediate denture, you will understand the procedure. But you can see in this picture that I have kept these two teeth over here, right? Later on, I can convert the same case into the definitive overdenture. But right now, this is a root canal treated and just cut off at some 2-3 millimeter from the gingival level and remove the other teeth, and immediately the denture is given. So this is immediate denture. There is something called the transitional overdenture, which is nothing but the removable partial denture, existing removable partial denture, which can be converted into the overdenture. And then there is a definitive overdenture. So now definitive overdenture classification is given by Hartwell, and we know that it is either non-coping, abutment with coping, abutment with attachments, and submerged vital roots. So let's see the pictures of one by one. This is something non-coping. It can be given with or without endodontic treatment. When you are giving a short, usually when you prepare the teeth a lot, you give the short coping. You keep the teeth very short according to the inter-arch distance. You will have to do the endodontic treatment. When you do not want to do the endodontic treatment, you should have more than sufficient inter-arch distance where you can reduce the teeth very little, and over that you can give the denture. But that is very difficult because very few patients you will get with very good inter-arch distance. So whenever you do with the root canal treatment, you can give the amalgam plug, do the fluoride treatment, and directly fabricate the denture over it. So this is something called a non-coping type of overdenture. Then there is a coping. There are usually two types: short coping and the long coping. The short copings will be 2 to 3 millimeter, and long copings will be 5 to 8 millimeter long. See, this is some case where you can prepare this, and wherever you're giving a short coping, you need to have the extension into the canal also, root canal also. So something like a post preparation you will have to do, and that post will give little retention to your coping. So these are something like a short coping. Then another variety of overdenture is the abutments with the attachments, right? So most of these attachments also will have the will be attached with the cast coping and with the post extension into it, right? So again, the attachment has got different classifications. So let's see what are the different type of attachments used for the overdenture. So it can be telescopic, it can be studs, it can be bar attachment, it can be locators or magnetic attachment. And these are further classified as splinted and non-splinted and resilient and rigid type of overdenture attachment. Sorry. So let's see few cases. One is this ball attachment. These are the prefabricated ball attachment with post inside. So this is a post and with the ball head. So it is directly cemented into the post space, like how you do the post and core, right? And then there is a female portion over here which is picked up in the denture. Simple form of ball attachment. Then there is another one is a customized ball attachment. Customized means you fabricate the coping and you fabricate the ball attachment into the laboratory. So you prepare the tooth, you prepare the post extension, and this is something you can see the copings with the, you can see the yellow cap here and the post extension, right? It is cemented. You can see the ball over here on the coping, the female portion on the coping, and that is then picked up in the denture. So this is what is the customized coping attachment type of attachment. Then there is a magnetic attachment. Again, the post preparation is done and the tooth preparation is done, and the keeper of the magnet is incorporated into the coping, and then there is a magnet placed over it, which is again picked up in the denture. Then there is a telescopic type of attachment where you have more than 2 teeth or 3 teeth. You can prepare this, and do the preparation and check the parallelism on the surveyor, cement the first coping. Over the first coping, you are going to put the second coping, secondary coping, and which you are going to pick up in the denture. So this is called the telescopic type of overdenture. Then there is something called a locator attachment. Locator attachment, as you might be knowing, that this requires a very little intra space. You can see the tooth is almost reduced at the level of the gingiva, right? And the locator attachments are then cemented. These are the attachments. In between, what you are seeing with the gold component is the attachment, and the others are the retentive caps and all. So they are cemented onto the tooth, and then the female cap, the steel housing is placed over it, and that is picked up in the denture. And then the last one is the bar supported overdenture. So this is, you can consider this as a splintered attachment, right? Others were non-splintered attachments. So you can splint this two abutment with the again the coping and the bar. And these are the sleeves which are placed on the bar and then picked up in the denture. So this is bar and sleeve type of attachment. So now let's do how we do the treatment planning for overdenture patients. So we basically require four kind of things. We consider four factors basically: the prosthetic factors, periodontal, endodontic, and caries management. So in prosthetic management, what we see is the location and distribution of abutments, right? So it's always preferable to use the anterior teeth than the posterior teeth. It is said usually that anterior teeth are having better proprioception than the posterior teeth. And posterior teeth sometimes interfere with the occlusal schemes and all. So it is always preferable to have the anterior teeth. The best possibility is when you have the two teeth present on each quadrant. So the four teeth, and specifically into that also cuspid and the second premolar are the best. Uh, 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 you can say the combination of the abutments. So here the canines are there and second premolars are there. Two nearby two adjacent teeth usually are not preferred because you will have a very thin section of acrylic in between two abutments, and it might lead to the weakening of the denture. So usually if you have the canine second premolar or canine and first molar, something like that will be a very good. If you do not have four teeth present, you can take tripodal design also, three teeth. If three teeth are not possible, then you can utilize even two canines, right? That also will give enough proprioception and support. That is the first location and distribution of your abutment. Second point is the crown root ratio. I would rather call it more than a crown root ratio. For me, what is more important is the root length, right? Because if you do not have enough root length, the root which is into the bone, you should have the enough, at least minimum 8 to 10 millimeter you should have. Then only you can place this post and the attachment into it, right? Another important factor is inter-arch distance. If you do not have enough inter-arch distance, you will have to select the different type of overdenture. You can give the non-coping type of overdenture or locators or something like. If you have enough inter-arch distance, you can just give the coping. Sometimes patient doesn't have a very high caries susceptibility. You can give non-coping type of overdenture also. So inter-arch distance also is very, very important factor in deciding the type of overdenture. And hard tissue. As I said, when you have the hard tissue undercut, sometimes it becomes very difficult to do the hygiene maintenance, and also this also you need to consider before you decide the overdenture treatment. Then of course periodontally they should be healthy. Sometimes we do not see under the teeth which are present where the attached zone of attached gingiva. If it is not there, you can do some kind of free gingival graft or something to create the attached zone of gingiva and then utilize those teeth for overdenture. Similarly, as I already discussed, the endodontic consideration also is very important. You have here main three advantage of doing root canal treatment of the abutment. That is, you can change the crown root ratio as per your favor. Means to make it more favorable, you can change the crown root ratio. If you have not done the endodontic treatment, you cannot do that. Right? Reduction of clinical crown provides an interocclusal distance also. So if you can reduce it more, you will get more interocclusal distance and it will become more favorable for securing the attachments and all. So when you are doing this, before you do this, you need to carefully evaluate whether the FPD or RPD is possible or not. Then only you decide on going for the overdenture because you are going to do the endodontic treatment of the abutment. Then of course you will have to see to it that you can manage the caries high index also patient. You will have to give the fluoride application, frequent checkups, and the scaling and all is required. That should be done. And that any treatment to the abutment if it is required, that also frequent recall and the follow-up treatment should be done. So that is all about the overdentures. So these are few commonly asked questions in MHS exams, so that you can just, you must be knowing, of course, all of you must be knowing about it, but then rationale of overdentures, advantages, disadvantages, indications, contraindications, definitions, and classification of attachments, right? And what is the, you can say the note on preventive prosthodontics. So here, overdenture is basically the concept of preventive prosthodontics, where you are preventing the resorption, you are preventing the loss of proprioception also.